Good morning. I really enjoyed that. I have nothing to disclose. So the objectives for my presentation this morning is we're going to look at a few models and terms that are very popular nowadays, what they mean and what they mean to us in our practices, particularly as it relates to our patients and how they are dealing with their issues. So look at patient engagement, patient-centered care, chronic health management strategies, and how they can improve outcomes for patients. We're going to contemplate the use of current technology to assist us in teaching and supporting our patients. And hopefully by the end, you'll be motivated to consider ways that you might employ some of these strategies in your practice settings. I'm from Alberta, and Alberta is fairly progressive, I think, for a healthcare system, Alberta Health Services. One of their core values in terms of patient care is patient engagement. The others are respect, accountability, transparency, safety, learning, and performance. So patient engagement is the collaboration with patients and their families, the healthcare providers involved in their care, research and education institutions, government, and the community, so pretty well everybody, and assists people or encourages people to take responsibility for their care. What matters to patients? What really is it? They want to be respected, they want to be listened to, they want to be involved, and they don't want to be confused. Most patients, not everybody, and that's why you have to really consider the patient in their situation. So questions that patients want answered is, what is my condition? What do I need to know to deal with it? And why is it important for me to do this? There's various elements, various models when it comes to patient engagement. This one considers the patient in terms of participation, so the act of them being involved in taking part, some action or attempt, and this must then be sustained. So it has to be kept up or continued as an action or a process. We often hear of patient compliance, and I think that's where this word comes into play. So their participation must continue. It must be managed, or the patient needs to bring about or succeed in accomplishing some activity in terms of their self-care. Self-efficacy is another term that we'll look at a little bit more closely, but it's really a belief in one's capabilities to be able to organize and execute courses of action that help manage their situation. And then the well-being. So there has to be some kind of a good outcome where the patient has a quality of life that they feel gives them more value and that they can have some control over. So the patient engagement from the Picker Institute in Europe, relationships and communication are one of the categories, and healthcare service and the system as well is another. So in terms of the relationships, it's respect, what they value, what they prefer, their involvement in their own decisions. And they need information, communication, and education, and that's often where one of the roles of the nurses comes in. And then there has to be some type of emotional support, ongoing support to some level. So they're not anxious, they're comfortable with their role and where they fit in the big picture. And then the healthcare system and that the patient is involved in has to be available and on the patient's side, I guess, in terms of coordinating their care, in terms of providing comfort, involvement, and transition and continuity so the patient feels supported. Self-efficacy is crucial in terms of patient engagement, so it is the person's sustained participation, ongoing participation, managing their health in a way that creates the self-efficacy, which is, again, their ability to do what is required and the belief that they actually can do it to manage their health issues. Goal setting is very important. I think that's something that we all have to consider with the patient. We can't set their goals for them. It's something that they have to look at and consider. Patient and family-centered care is also a bit of a buzzword in healthcare nowadays, and certainly in Alberta. And the key components of that are communication in all aspects between patient and healthcare provider. Sometimes technology is a part of that to varying degrees, and that's one of the things I'll be looking at in this talk. Patients feel that they're treated well. A team-based approach is very critical, I think, in becoming more and more popular in healthcare. And then transitions of care. So when you move from one area to another, for example, acute care to back to home or to the community. So patient-centered care sees the patients and their families as integral members of the healthcare team. They're not out there and we're telling them what to do, but they are actually a very important part of the team, and they need to be involved in all the aspects of their care. There's evidence that shows that the benefits are hugely increased satisfaction to the patient and their families. Their quality and safety, quality of care is improved, and actually reduces costs. And that's one of the reasons that it's being very carefully considered at all levels of governance at this point. So nothing about me without me. There are various chronic disease models, and really, to some degree, incontinence must be considered as a chronic condition or a situation. It has to be controlled and maintained over time. And again, these are self-management support models versus treatments or interventions that are done to the patient. It motivates patients to understand their condition, so they understand what's going on in their bodies, why they're having the issues they have, and how they can live successfully with them. They can't always be cured. They can't always be back to the way they want to be, but they have to be able to move forward from where they're at with interventions and strategies that improve their quality of life. So some of the examples, moving outside Canada, is a Stanford model from the actually probably the mid-1980s. It's a model that reduces patients' sense of isolation. Initially, I believe it was started with patients with arthritis. So it facilitates their self-efficacy by providing groups with two leaders. One is a clinical member, one is a lay member with training. They have group sessions for approximately 6 weeks in length. Participants feel empowered by the end. It involves goal setting and problem solving. There's the Flinders model from Australia, not so much a group situation, more one-on-one, very comprehensive and formalized. There's others. We're not going to go into a lot of detail on these. We just simply don't have the time. But there's the TPS model that, again, facilitates behavior change with patients through trained patient navigators. In the institution where I work, an outpatient clinic setting, they have patient navigators for women with breast cancer. It walks them through the system, helps them know what to anticipate, basically a huge support system for them. The McCall Institute, they look at 6 elements, being the healthcare organization, community resources, self-management support, the delivery system design, decision support, and clinical information systems. The care transition intervention looks really at patients that are released from hospital, and there's 4 pillars that it's based on, including management of medications, follow-up with providers so they're not left dangling. They know what the next step is. They know what to watch for in terms of if this happens, what I should do, where I should go, who I should call, and patient-centered records where they have access to varying degrees of their medical records. So we're going to talk a little bit now about our center where I work. I've been working in this area since about 1998. We have never followed any particular model, but as I've done some research into this whole patient engagement, it's basically a passion of mine. I see many, many elements that we've sort of, we're using, which has brought us to where we are today. So initially, before our clinic existed, there were 2 urogynecologists basically working in private practice at an ambulatory outpatient clinic. There was 1 urodynamic nurse, and there was 1 nurse assisting them with their clinics. I entered the picture about this time. I started doing relief with urodynamics, and about 2000, these two urogynecologists asked if I would assist them in their practices by doing pessary fittings and follow-ups. Our clinic came into being in 2002 through the vision of our medical director and our nurse manager at the time. We started growing initially it was slowly with 3 urogynecologists, 2 nurses, and 1 physiotherapist. And about that time, I did the Canadian Nurse Continence Advisor Association program and started seeing patients of my own in my own clinic with assessments and conservative therapies. Fast forward to now. Our clinic the only constant has been change, lots of growth. We now have 5 urogynecologists practicing, 1 family doctor. There is a team of about 13 nurses. They're not all full-time. 1 nurse practitioner, myself as the clinical nurse specialist, 8 RNs that have private practice within the clinic. And what I mean is they have their independent clinics where they see patients. And then 3 LPNs whose role is physician support in their clinics. We have 2 physiotherapists. In my opinion, that's one of the weaker links. We need more physio support. And then a number of clerical as well. What our clinic offers, first and foremost, is education, assessments, conservative therapy, pessary fittings, some follow-ups. We do teach them self-management and often discharge them to the care of their family doctors, but we're always available. Medical treatment, medications, and that's basically the role of the family doctor and the nurse practitioner. Surgical intervention, urodynamic testing, cystoscopy, sacral nerve stimulation, and physical therapy as well. And here I just highlighted where the nursing role fits in all these aspects. So nurses have quite a varied role, very interesting role. We have high retention, very gratifying work. One of the mainstays of our program has been patient education, and the purpose was to provide women with knowledge and understanding of their issues, which allows them then to make their own treatment choices. So they are not told that you need to do this, you need to do that. They're given the options and they make those choices themselves, which really is patient engagement, patient-centered care. In 2000, when the doctors were basically working on their own, there was a lot of, excuse me, a lot of repetition of the same information to each patient. And at that point, I suggested if it was okay with them, could I start an educational session to provide this education in a sort of semi-formal situation. And we started with 1 workshop a month on an optional basis. The physicians started noticing a huge difference in their patients because they came equipped with knowledge, with understanding. They knew the language, they knew what their options were. And we increased the frequency of the workshops. Now we are teaching 4 in-house sessions a week, approximately 2.5 hours in length. And we have an online version, which we started using in May of this year. We picked the arbitrary age of 80 for a requirement for patients to attend this session. We just found that over 80, it was too much information, not necessarily all relevant to them, so we provide individualized education for our patients that are over 80. So before their first clinical appointment, before they see a provider, they do attend or view these educational sessions, and then based on the information they receive, they select which direction they'd like to pursue. It's not written in stone. There's fluid movement within the different areas in terms of conservative, surgical, etc. within the clinic. The feedback we've received from patients over these years has been tremendous, mostly all positive with some good critical suggestions as well. But the comments that we've often received are they feel normalized, they're not the only one, they're not a freak, they don't have issues that they're embarrassed about, they feel very supported. And just very positive feedback about the content. The nurses now are rotating to teach the workshops and they enjoy it a lot. It gives them some variety in their work. They enjoy the feedback and the interaction in the groups. We also have been offering a telehealth class once per month to our rural patients. That probably will decrease in frequency with the new online classes that we're offering. One of the dilemmas, and it's been lots of, as I said, changes as we see the benefits or see the effects of our processes is that after the first workshop, once the patient selected, there was a longer waiting list initially until their first appointment. Some of the feedback we got is the patients found it hard to take half a day off work, hard to find parking, hard to find childcare in some situations, and many times they asked if the classes could be offered in an area that's closer to where they live, perhaps in the evenings, perhaps on weekends. And thus, we decided that we would move forward with that and use technology to their patients' advantage. So they didn't have to come in to the clinic, they didn't have to take time off work, etc. In 2013, my task was to start writing the scripts for these online classes. We broke it into 5 segments so they were easier to manage, I guess, instead of watching it all in one sitting. They're approximately 20 minutes plus or minus in length each. And there was involvement from the physicians in our clinic, one in particular on the committee, as well as physiotherapy, as well as nursing. So each of the online classes has a similar looking title. So the first would be Introduction to Pelvic Floor Issues in the Pelvic Floor Clinic. So they are somewhat clinic specific to some degree, although the value is for anyone. The objectives for each module, they're very clear, and for the first one is to help you understand how your pelvic floor should normally be working, to help you identify what might be happening to cause the symptoms you're experiencing, to provide information, suggestions that might help you manage your symptoms, and to help you select the best treatment options for you. Then at the end of each slide, there were sort of some specific take-home thoughts. Can you understand where your pelvic floor is, how it should be working? Can you better understand the issue that you've been referred to the clinic for? And can you identify some associated factors? Module 2 is specific to your pelvic organ prolapse. Module 3 to incontinence. Module 4, lower bowel management. We tried to say it in a nice way instead of constipation, fecal incontinence. And then Module 5, again, fairly specific to the clinic process and to what happens from here on. So the objectives are to summarize, to help them ensure they understand what their role is in managing their symptoms, because there's things we can't do for them, they have to do themselves. To assist them in selecting their direction for care, and then specifically about what to expect in the clinic and what they must do to ensure that they do have a clinical appointment. There's some decision-making tools, very simple. Do you have prolapse? It's just an example of one. Yes. How much of a bother? Well, it's really not a bother, but I do believe I have some. Well, you probably don't have to do anything about it, but you need to continue to protect your pelvic floor from developing prolapse so it doesn't get worse. I have some prolapse, and yes, it is a bother. Is it enough of a bother to consider a pessary or surgery? Or you can improve it by watching, waiting, protecting your pelvic floor, and see how things go. And then with a lot, directions as to pessary or surgical intervention. And then prevention, there's a focus on prevention as well. I don't have any symptoms of prolapse, but consider that approximately half of all women do develop prolapse from some of these things. Help prevent it from occurring in your situation, and then the take-home thoughts, again, at the end of the 5th module. So we needed a lot of consensus on the script. There was a lot of negotiating back and forth about how to say it, the wording, the grammar, etc. It had to be submitted to our legal department to ensure that they were okay with the content and the wording. I needed to find or to receive source permission to use certain pictures, graphics, etc. And then we had to decide what we would do for direct filming or for using pictures or PowerPoint slides and voiceover. There's disclaimer slides that were required as well, and it was somewhat complicated and time-consuming. And once we had the product, then what do we do with it? It has to be housed somewhere. We did have a very archaic clinic website, which was kind of useless, basically. So we were able to further develop that. We added external links to things like the Canadian Continence Society, etc. There's options for patients to print out clinic documents. Alberta now has an online software program called My Health Alberta, which basically governs all the clinical messages that patients receive, and we had to work closely with them as well. So the benefits of this online system is that it's convenient for patients. They can watch it in their own home at the best time for them. They can watch it again and again. They can share it with family members or friends, and we did receive feedback that that's exactly what is happening. I've been stopped in the street saying, "You don't know me, but you were in my living room last night." It's kind of interesting. And we created an accompanying booklet as well, which highlights some of the main features from the workshops, just to summarize them for the patients, which can be downloaded as well. We have already created some supplemental modules and are working on some more with additional information on specific topics. There's one called Frequently Asked Questions about pessary care, which patients that are more interested in pessaries can get extra information on. Perhaps in the future we may be able to consider online registration and transfer of information. Right now the firewalls in Alberta Health Services do not protect privacy of patients, so we can't pursue that. And then an interactive system would be ideal as well. I think I will avoid, I just had a 3-minute clip, but I won't, because of time, won't be showing that to you. So in summary, today we looked at patient engagement, patient-centered care, chronic disease models, self-efficacy, to see how these relate to our patients with pelvic floor dysfunction, and to look at how the clinic where I work in used technology to enable patients to learn and promote decision-making and self-care. And now I think it's up to you to consider in your own situations, in your own work settings, what you can do perhaps to keep with the times and work with your patients in providing optimal care for them, using whatever means of communication is available for you. I'm open to any questions.
Thank you very much, Grace. That was really, really useful. Just a couple of questions. In terms of those people who selected a lot in terms of bother, did you have a feel, or do you have a feel of how many people converted to a use of a pessary or going down the road for surgery?
I can tell you that approximately 55 to 60% of patients who attended the in-house classes, we don't have the data from the online at this point, chose to move in a conservative direction initially. And at that time as well, about between 17 and 18% of them felt that they could self-manage their symptoms without coming into the clinic for a visit, a clinical appointment. So now there was some movement in that, and we haven't tracked the numbers, how many ultimately did see a physician, did go on to surgery, but that was the initial direction that patients selected.
Thank you.
Yeah.
We've used some technology and we found the same. It does increase self-management opportunities.
Definitely.
The other thing was terminology. Have you found that some people have needed some guidance on what incontinence means, for example? So have you offered a glossary of terms?
The terms are quite well defined within the modules, and it's also been previewed for the educational level, so they're geared to, I think, about a grade 5, grade 6 level of comprehension, so they're fairly simple in the terminology that is used. Incontinence would be defined as to what it means, for example. So we've certainly kept it at a level that I would suggest most people can understand. We haven't done any interpretation of the workshops into other languages at this point. That's something that, again, is on the back burner potentially for the future.
Many thanks, Grace. That is really impressive. I just wanted to know, obviously your work is focused on women's health in the community. Yes. Are there equivalent approaches for men's health as well? Are they a neglected part of the population, or can you also say there's equally impressive things going on for them as well?
That's never been an area that I've been working in. So there isn't as much for men, without a doubt. I think that is somewhat neglected. I mean, there are urology clinics, good urology clinics with great clinicians, and it's certainly good nursing support there. I don't believe they have any formalized type of education system that we've developed, though.
Blazing a trail that they need to follow.
That would be ideal.
So I'm just curious about the budget to have this kind of program going on.
Well, I can honestly say I have no idea what it cost because it was all paid for by Alberta Health Services. My role, the filming, it was all supported by the digital media department of Alberta Health Services. So I think it was money well spent, but I have no idea what the actual cost of the project would amount to. And I know not everybody has the benefit of having that type of support behind them. So. Okay, thank you very much.